So I'll introduce the next speaker. It's really a pleasure for me to introduce Anthony Christodoulou. He's really, we are fortunate to have him over from UIUC after training with JP Liang there for a PhD, and joined us at the postdoc in 2015 and stayed on at the faculty at Cedars-Sinai and UCLA. And he's really blossomed in the last few years by developing this multitasking technique, allows us to do continuous quantification, multi-parametric motion resolved imaging. And it's been applied to many different organs in the body and from top to the toe. So it's a really amazing technique. And he's been, as I mentioned this morning, it's been really played a key role in the organization of this meeting in the last 2 years as a chair of the abstract committee. Thank you, Anthony.
All right, thank you for the introduction, and it's a relief to see all of this actually happening and everybody's here and we're doing it, so it's fantastic. And maybe I have the wrong one. Should just be this, right? Oh, there's a third one. You know, I'm supposed to be partly responsible for the AV, so I have no one to blame but myself. So as we know, turning to cardiovascular MR, there's really just so much information that we can get from MRI. Not just the cine imaging where we can see structure and function, but really all the tissue characterization where we have all these different complementary biomarkers, T1, ECV, T2, T2 star, as well as our ability to actually measure and map perfusion, and of course, bread and butter like gadolinium enhancement. So this is really the strength of CMR, but it's a bit of a double-edged sword in that all of these things that we are sensitive to are happening all at the same time, right? And so they are overlapping each other in a way that makes imaging quite difficult. Because if you were just to do high-speed imaging, this is what you would see. You would have contrast changes, you would have respiratory motion, you would have cardiac motion, and if you want to get into quantification, these things are now confounding each other. And that's usually how we think about these things, as confounders. And so our typical approach is to get rid of confounders. So you heard Dr. Golden this morning mention that when he was in med school 35 years ago, people were still doing gating. Well, I have to say we're still gating today. This is the main way of doing imaging. So if we want to do, let's say, T1 mapping, then we have to get rid of motion. So if you synchronize your imaging with the ECG trigger, then you can get rid of the appearance of cardiac motion when it works. You can ask the patient to hold their breath, and if they can adhere to that, you can get rid of respiratory motion. And then you've still got different other physical processes that you're trying to quantify, and we can do our contrast timings, et cetera, so that we can isolate a single process. So we've done a lot of work to get rid of all that clinically useful information and just get to a single measurement, such as inversion recovery for T1 mapping. And this is really the way that we do this. And I have to say that CMR is ahead of many other fields in that we're actually using quantitative imaging in the clinic, but it's still a very unwieldy way of doing it. So that has led us to exams that look something like this, where you have a long series of different completely unrelated scans. They're all triggered. They're all done with a series of breath holds, which can be quite exhausting. And they are done in different breath holds, which means we actually, even though we're getting all of this wonderful multi-parameter information, they're all a little bit misaligned. And so in order to really do deep multi-parameter analysis and fusion, we've created the problem by having them misaligned. So all of these difficulties, perceived difficulty or actual difficulty, whatever your take on this is, has limited CMR to really only being at the most advanced academic medical centers and limited its availability throughout the world. So I would argue that how we should be doing CMR, if we can pull it off, is to acquire all of these things at once simultaneously. So if we could get down to a short exam in a single push button, where we are, instead of trying to do all of these things one by one, actually interrogating all of these overlapping processes together at the same time, then we could have a much friendlier workflow and a much more accessible exam. So how can we actually get there? So there is a different way, which is instead of getting rid of all the motion, let's work with it. And so this is multidimensional imaging. If we assign all of these things that are happening to their own time dimension, and I'll show what that looks like in a moment, then that means that we don't actually have to use the ECG. We're going to work with the cardiac motion. The patient can breathe. They don't have to go through 30, 40 breath holds or whatever it is different at every center. And by resolving multiple tissue processes at once, you can do multi-parameter mapping. So a single scan can actually perform multiple imaging tasks. So all I mean by multi-dimensional imaging is it's fancy sorting of our images. Not even that fancy, it's just sorting our images. So if you had a cardiac row and a respiratory column, then as your images come in, they actually come in a grid like this. And so by imposing this structure, we are having multiple time dimensions, we say. Now, the challenge behind multidimensional imaging is that we have exponential growth. This is known as the curse of dimensionality. So the number of images, and therefore your scan time and computation, increase exponentially with the number of dimensions you try to image. So what can be done in the space of a breath hold for cardiac gets a little more difficult. You do respiratory navigation, fine, it's a little bit longer, but you get that free breathing. As soon as you start trying to get multiple contrasts on top of this, etc., your imaging time would explode. So although that's discouraging, this curse of dimensionality, there's also the other side of this coin is the blessing of dimensionality. And this is really an opportunity, which is that high-dimensional spaces lend themselves very well to sparse representations, so we'll be able to use things like compressed sensing, etc. But also, we didn't place these images randomly in a structure. We put them in according to cardiac phase, respiratory position, contrast weighting. And there's an underlying structure that we should be able to exploit the redundancy between those images. And so this is a growing trend in cardiovascular MR reconstruction and imaging. It really started in terms of using the multidimensionality with XD grasp, and this is something that Matthias Stuber's group has really done amazing things in, and we're going to see a little bit of that on Wednesday from Ruud van Hesvik, so I'm not going to go into it now. But we also, our entry into this is something called multitasking, which moved from compressed sensing to low-rank tensors, which is a different mechanism that scales specifically well for multidimensional imaging. So this is what multitasking looks like. We allow our sequences to be completely free running, continuous acquisition, completely free breathing. There's a lot going on. You might have T1 recovery and T2 decay. They're overlapping. We sort them out into a multidimensional space, and then we use a basis function model, which is our low-rank tensor model, to directly combat that curse of dimensionality. And without going into the details, the reason it works is because all of a sudden scan time and computation grow linearly with dimensions instead of exponentially. And so that means that you can do really, really high acceleration when you have a lot of dimensions. So here's just an example of what it looks like. You can do one scan, and after the fact, because you put all these images into a nice structure, you can isolate the different dynamics that are going on. So you can get cardiac motion at any contrast, any T1, T2 weighting you want after the fact without having to use scouts or triggering. You can isolate T1 recovery at a single motion state, T2 at a single motion state. And the power of this, of course, that we want to do is for the quantification. So not only do you get that, but you actually get co-registered T1 and T2 maps that are synchronized as well. So in our first study, we just did a small pilot study showing the value of having co-registered T1 and T2 maps all in one scan, which is we had 10 acute MI patients, showed T1 on its own moderately predictive of late gadolinium enhancement, T2 on its own a little bit more predictive, but really when you put the two together, of course, they have complementary information where you get much higher sensitivity and specificity in being able to have something like a non-contrast replacement of LGE. So we have taken this now, this is work from Xianglun Vincent Mao, who's here today and will be talking later on, I believe on Thursday, where we've actually pushed this now to simultaneous multi-slice so that we can do T1, T2 mapping, 3 slices without ECG or breath holds within the space of 3 minutes. And so if you imagine actually how many breath holds that typically is, that's 6 breath holds, that's a pretty attractive replacement, I would hope, for the conventional mapping that we do today. We've done some validation studies. So want to always show people, say, what happens when the heart rate goes fast? Well, this is what it looks like in rats, where they have 350 beats per minute, and essentially no change to specially handle that. This is something that directly works. And we can do ECV here. So we have a study in a HFpEF animal model with these dull salt sensitive rats where we want to do a longitudinal study. But if you want to measure fibrosis and you do it with sacrificing the animals, there goes your longitudinal study. So we have now been developing ECV to be able to do this in rats. And as you can see here, we actually do have pretty good correlation between our ECV measures and the fibrosis staining. We are pushing this to more and more biomarkers to try to collect everything we can, make this as informational as possible. I don't want to talk about this one too much because this is actually going to be presented on Thursday morning by Tianle Chao, but this is, in brief, T1, T2, T2 star, and fat fraction mapping in the heart all in one. And we are not the only group working in this direction. So this is work from René Botner and Claudia Prieto, where they have the HD Prost framework, which is doing 3D free-running cardiac resolve mapping. So they also use a low-rank tensor concept, but they actually incorporate self-similarity of the images to go one step further. And you can see here some examples of 3D free-running joint T1, T2 mapping that also, because it's cardiac resolve, gives you cine images. And again, I know we're going to hear more from Jesse Hamilton, I believe, tomorrow, but just to show that fingerprinting is now also being able to do, they've always done multi-parameter mapping, but now cardiac resolved as well, to try to be able to do T1, T2 cine on top of it. One area where we're very excited about multitasking is being able to handle contrast agent dynamics on top of everything else. So it's not just about relaxation. So here we have an example of doing saturation recovery imaging, but we actually are treating not only the T1 recovery as a time dimension for T1 mapping, but also the gadolinium dynamics to be able to map perfusion. And the benefit of being able to have a T1 recovery dimension here is actually that you can quantify the contrast agent concentration without a saturation effect. So this is really important when you're doing quantitative myocardial perfusion imaging. And here are some examples of doing this in 3D, where we do, again, free breathing, 20 cardiac phases, and just showing 2 of the cardiac phases, diastole and systole, for 3 different reformats here. And in rest, this agrees relatively well with a standard sequence. We have a PET-MR scanner at Cedars-Sinai, so we actually did a truly simultaneous PET-MR perfusion and showed that in pigs we had a very, very high ICC agreement, 0.95, between the myocardial perfusion reserve from multitasking and the simultaneous PET. And so we're moving towards, as I said, trying to really get an all-in-one exam at the push of a button. And so this is where we are today for this. We actually have put together T1, T2, ECV, LGE, and cine all in one. And this is work that Vincent is going to be showing Thursday morning. So again, I will just hopefully leave it as an appetizer for the full meal of the details he'll be giving. So the outlook of all these types of methods is really that if we can get rid of the ECG reliance, if we can get rid of breath holds, make really user-friendly and patient-friendly exams, then we have not only made an exam that will hopefully be more accessible, but also provides extremely rich information, these co-registered synchronized maps that are really ready-made for multi-parameter analysis. And there's a lot of work to actually get this out there. These are still mostly ideas in the research field. There's a lot of validation that needs to be done. We actually have to explore whether this is expanding access to patients who normally wouldn't get referred for CMR, either because of worries about their arrhythmia or because they're too sick to do breath holds. Building in all the additional biomarkers that we actually need to replace an entire exam. And of course, all of these have really shifted the burden from the technologist and the patient over to computation. So we need online reconstruction, integration into clinical workflow, and also software updates to be able to handle the huge number of images that we're generating with this. So we're going to have to really think and work with vendors on how we can natively use multi-dimensional images. And in the end, as I said, you've got this really rich multi-parameter data. We need to learn how to use that to actually take all that data for diagnosis, risk prediction, therapy monitoring, and more. And with that, I have a lot of people to acknowledge, collaborators, slide contributors, and grant support. And thank you very, very much.
Thanks, Anthony.